trying to answer the dreaded therapeutic communication questions, which, if you have not had any of these, they can be quite subjective, okay? And there needs to be more information in regards to pharmacology for the psych drugs, okay? So what I have done, instead of sitting in my office twiddling my thumbs, these are additional classes to help you, okay? Yes, will you see therapeutic communication questions? When I start teaching bipolar and major depressive disorder, you're going to see therapeutic communication questions. And today, because of time, I'm going to focus on trying to help you with answering therapeutic communication questions, solely because of time. Next Wednesday, we'll spend that on pharmacology. Now, not that when I teach bipolar, I will re-emphasize those medications. This is additional to help give you that foundation before you get to 213, okay? So, that's why I'm doing this, okay? So, another reason, per the NCLEX test plan, as I told the seniors, you have 6 to 12% psychologic, okay? I have had 2 students already tell me, I had 12%, Miss Rumble. One passed, the other one didn't, okay? And that's going to be your luck, and that's how you should think. I could have 12% of mental health, okay? So that's another reason we need to emphasize this material and just really try to bring out the need to know and to help you with these questions. I have students come into my office going, well, that one sounded right. Okay, so I get this picture of you sitting on the pond with a fishing pole. And in the pond, you either had 4 questions or you had 2 questions. And you're fishing. Nurses don't fish for answers, okay? We don't fish. You cannot fish at NCLEX. Or the student come in and said, oh, I guessed it that one, I got it right. You going to guess on NCLEX? That is not how we approach nursing questions, okay? Because in my mind, I'm sitting there going, God, we need prayer right now, okay? Because this is considered a different animal, okay? Also, I want to help and try and prepare you for the psych clinical. You know, I'm going in the first day, student says, I'm nervous. Well, I said, that's normal. That's normal. This is totally different med surgery. I don't know what to say. Well, that's not good. I said, you remember therapeutic, non-therapeutic? Not really. I thought, oh, God, we need prayer. We need prayer. So, again, I thought, let's try to help you a little bit, okay? So, when you go to the VA, or as Renee said, Ms. Hyde said, you're going to see patients with mental health disorders in the acute care setting, in the emergency department, in Walmart. They are everywhere, okay? So, but we want you to have a foundation in how to manage a patient with a mental health disorder, okay? Mental health nursing can be summed up in 2 nice words: a communication course, okay? Why? When you look at the primary interventions for a client diagnosed with a mental health disorder, they are cognitive behavioral therapy, which is let's talk, okay, and pharmacology. The beauty of the patients that we are going to be dealing with, the majority will have taken their meds. You will have some that have refused their meds, and you're like, there's something wrong with you, you know. So, because of those reasons. So those are the 2 big interventions. Now, I will tell you, as a nurse, you are going to rely on observation. Not just observation of your clients, but observation of yourself. Okay? What do I mean by that? Don't do this in front of a patient. What does that say to a patient? You're closed. Okay? Now, this is very comfortable to me, you know, but I found myself having to do this, you know, trying to make sure my posture, I didn't look like, you know, and it can be very hard. You need to think about what you are doing. Don't raise your eyebrows. Don't laugh when they laugh in group. It can be taken as insensitive. Don't stand behind them. Don't touch them. Do not go in their rooms. Don't put yourself in a corner. At the VA in Salisbury, we have high-risk violence. I don't think they have those at Rowan. We have them at the VA. You are going to encounter this in the acute side, okay? High-risk violence. They give me this little picture, and they all look alike to me. So I just tell the student, guess what? Everybody's high-risk violence. So remember your non-verbal behavior. If they ask you to play a game, which you will play a lot of games, don't be competitive. I'm like, let them win, let them win, let them win, people. Don't set them off, okay? So, you do not want to get competitive in this environment. So, oftentimes we tell the students, let them win, let them win. For those reasons, we don't want to upset anyone, okay? Also, if they start coming into your space, just back away. Most of them will stop, or the nurse will stop them. They are not allowed to touch you. If they touch you, you need to let me know, and the nurse will say something to them, okay? They're just people that have gone through horrific issues. Okay, for example, I am talking to a patient, and oftentimes I ask, you know, can I ask you what brought you to the VA? Yes, you can. Can you tell me about this? Okay. It was very sad. You know, he said, I was on this rural road, and I got in my car, and I started driving, and I closed my eyes, and I let go of the steering wheel. How do you respond to that, guys? What are you going to say? Don't raise your eyebrows. Okay? Don't give me this grin, you know. Also, don't sit in the corner and you guys chit-chatting. It's fine to talk, but you're talking with patience, because they see that as, you don't care. Okay, so again, what is my point? I cannot tell you the significance of therapeutic and non-therapeutic. Okay? And you will have to make a conscious effort to really look at your non-verbal communication. Okay? You know, it's funny to me, now that I've been teaching psych quite a bit, Renee's standing up here going over that syllabus, and I start looking at all the nonverbal communication going around in the class, and it's quite entertaining. But that's beside the point. So, why that is very, very important. So I want you to think about that, okay? When you come to clinical, don't be wearing big old jewelry, diamond earrings, you know, no. Simple watch is all you need, okay? The hard part, most students get a handle on that pretty quickly. The hard part is those dreaded therapeutic communication questions. Now, I will tell you that when you start answering those on exams, you need to ingrain in your mind what's therapeutic and what's considered non-therapeutic. That leads you to the answer. Not, well, that sounds good. That doesn't sound right. Well, that sounded fine to me. You know? I'm sorry it didn't sound fine to you. So, again, you've got to keep theory in your mind. Okay? Very, very important. So what do I mean by that? You know, if you want to, refer to Chapter 8 and that thing and go to sleep, be my guest. But that's where you'll find it, Chapter 8, for my anal retentive people. Okay? And I just know you're going to learn everything there is to know about therapeutic communication and non-therapeutic communication on that dang PR. Right? Look at you. You're going to learn everything you need to know by doing that PR?
Yeah.
Huh? How many times have you written a PR?
I thought we were done.
See, I've been doing this too long. Yeah, I know. So, how do you learn the best way to identify therapeutic? Start looking at non-therapeutic. For example, don't approve what they say. Don't disapprove what they say. Okay? Don't probe for answers. Can silence get someone to talk? Oh, yes, it can. If you're using the right nonverbal language, caring, concern, look on your face, yes, it can. Okay? Don't reject what they say. And above all, don't give them advice. Please. You know? So, when you start looking at what I can't do, if you get those ingrained in your mind, then you kind of think, well, everything else must be okay. Right? Broad, general statements. Tell me more. Don't ask why. You know, that's like me saying, why'd you wear that today? What kind of message does that send to you? You know, it sends a very negative message. Don't ask why. Very open-ended questions. That was something I had to try and point out to the senior class last time. That's a yes and no answer. That's not the best answer. Yes and no answers are not the best answer. Okay? So these are the things that I want you to think about as we start looking at more tools, more ways to answer the dreaded therapeutic communication questions. Why? You're going to have them on these exams, in particular with mental health disorders. I've already told you why. Talk therapy, meds. That's next Wednesday. Okay? So, those are the critical components as far as treatment. So that is why we're focusing. This is why I'm doing this. Okay? So, I want to try and help you. Also, you want to be thinking, I could have 12% on NCLEX. That could be me. So, as a generalist nursing student, you need to have this foundation. And I don't want it to start when you're in 213. Okay. Now, on your slides, you will see I put some cute little things about testing and learning style. Did everybody see that? No. I think it's lightening up. Well, I want you to go to sleep. Can you see it now?
Mm-hmm. Yeah, it's getting brighter.
Is it better?
Mm-hmm.
Okay, because I know see, now I'm sitting here thinking, if one of you had this pulled out, or you try to buy something on Amazon, right? See, I've been doing this too long. Okay. Okay. Now with this, I gone through some general. Again, we are finding that a student comes back to me and says, I had 25 multiple response. Guys, that alone is increasing the difficulty of NCLEX. Okay, those 10 questions are hard. Do you agree they're hard? I think they're hard. Okay, so we've got to get you better prepared. Don't you love it? Okay. Again, I made this a point. Number 2, we are not trying to trick you. We want you to be successful in class and on NCLEX. And another thing, again, theory-based. What is NCLEX? All it cares about is you're safe. That's it. You can be the best nursing student in class, but NCLEX, all it wants is you're safe. Okay, just tidbits. Most of you probably already know this. I've given you some ideas. If you feel like you're not getting topics or whatever, but I think most second-year students should have a little bit of a handle on this. Please remember, this is something a lot of my students don't understand. Concepts build. What do I mean by that? That means essentially you're going to learn about what? Angina. Well, guess what? In 213, you're going to learn about cardiogenic shock and myocardial infarction. You're going to learn about inflammation elimination. In 213, you're going to learn about sepsis, septic shock, and renal failure. Concepts build. So, if you feel like your foundation is you just quite don't get it, see someone now. Don't wait. These you probably already know. These are things that I saw in the senior course. So, help you on your test. Again, this is taken from the NCLEX test plan in regards to therapeutic communication. So that says to you, they're going to be there, and we're going to try and help prepare you, of course. Okay. Again, refer to Chapter 8 if you want to review the theory background, but this is pretty much the need to know. This is just a nice little mnemonic to remind us all about active listening. That's probably something that a lot of us, you know, when we're at home and someone's talking to us, you know, we kind of hear their voice, but that is not active listening. Okay, there's a big difference in that. Okay, so let's look at this. And I do have a list of questions that we're going to go over, and don't look at the answers. Because, why did I put the answers even on there? Because before I left today, y'all would say, Miss Rumble, where's the answers? Miss Rumble, I can't do these without answers. So, yes, I put the answers, but don't look at them. Try to answer the question based on what you know about therapeutic and non-therapeutic. Okay? And we're going to look at a little bit more of that. Okay? So when you have a question that is a therapeutic communication question, first of all, try to identify what is non-therapeutic. Again, if it is telling the client what to do without regard to the client's feelings, remember, this is not about you. So if you see something in a distractor that says the nurse's feelings, well, that's an automatic no-no. Okay? Again, yes and no. Not the best answer. Seeking reasons. What about a dog? You're asking why. Don't ask why. I just just said, that's fine. Okay, so if Y's in there, don't choose it. Okay, again, approval or disapproval. All of this is non-therapeutic. Okay, and what I've done is I've put even a little more additional information in here to help you as you now progress in the second year. Okay, false reassurance, no, it's going to be okay. If you get a good night's sleep, it'll be fine. No. Okay, again, you're trying to interpret their behavior. That is not your job. You're not there to interpret what they've been through and why they're acting the way they are. No. Again, it is not about you. So if you see the nurse in a distractor, which is a potential answer, then no. Okay, so I've added additional stuff here. Do not, as I stated, approve or disapprove. Okay? Again, you are not there to pass judgment, not on any patient. So this can help you really with any patient. Examples. Try to give you examples. Don't say that is good. Or you shouldn't be doing that. So again, is there a question? You guys okay? You all right? Okay. Try to give you examples. Reassure. That says, I don't need to worry about this as a patient. I guess, I don't know why I feel this way. I would not worry about that if I were you. Okay? These are things, and again, I put in bold, do nots. So if tomorrow, or you know, if tonight you say, I'm nervous, that's a normal response, because this is a different world, okay? You know, you think about vital signs of a dust. No. Okay. You're going to be drawing pictures, playing cards, talking, and I'm hoping in the evening we'll have some recreational activity which was another reason I want to take students to the evening, another way for students to, again, participate with the client instead of just group.
I have a question.
Yeah.
Alright, you said that, like, when you go in to meet somebody, you ask them, you know, can you tell me what brought, or why are you here, or what...
Not why.
What brought you in here? Or,
what?
Okay. What if that is what sets them off talking about it?
Well, again, you know, you always have that fear.
Like, if they have post-traumatic stress, right, then it could be from past war or whatever. If they start talking about the war, that might set them off, correct?
Good.
So, how do you judge that?
We'll talk more about that when we talk about the disorders. But anytime you see an escalation in the behavior, do you know what I mean by that?
Redirect.
Try to redirect.
Yep.
There you go. Redirect. Or we had one last year that was quite disruptive. And I don't know, I guess because I'm old, I just thought, well, he can't hurt me when I... Yeah, you really can't. So, but I would redirect him. Like, I would take him to another room. You guys, I will tell you, if you take them to another room, don't ever close the door. Okay? Ever close the door. If you are going out a door, you always make sure that door locks, right, behind you, because they will elope if allowed. Redirection. But anytime you see escalations in behavior, okay, we had this happen last year, and I'm just going to tell you so you know, yes, the patient became violent, and what does that mean for us? We go on lockdown. which means we sit our little fannies right there until somebody says we can leave safely. And I'm just like, okay. You know, and they will take them down, literally take them down when they're violent. Also at the VA, if you're with me at the VA, I will try to get you and to show you the 4-point restraint room, seclusion, which is scary. It's very scary. But again, when behaviors are escalating, you remember like I said yesterday, to make a phone call is a privilege because their behaviors have been maintained. Doesn't mean we're always, improving, but we're maintaining behaviors that are acceptable within the environment. Washing clothes is a privilege. Okay, the dang thing's locked up. So if the patient, that's because of their behaviors have been maintained appropriately for that environment. Okay. So it's definitely something I know a lot of you will be thinking about. Hopefully, yes, we're human. We're always going to be therapeutic and non-therapeutic. That's human. I'm just trying to reiterate to you specifics that hopefully you will think about, okay, as you enter this area, okay? Again, interpreting. Okay, you're trying to look at the meaning. Okay, what you really mean is. Instead, use restatement. So you're saying you're worried. Does everybody see the difference? So you say you're worried. That's restatement instead of you. Okay? I hate this thing. Probing, again. Probing for answers can set the client off, their behaviors will escalate, or they'll shut down. They may not want to talk. And that's okay. Go talk to somebody else. Go draw pictures with so-and-so. That's okay. Again, don't advise. You should never advise any patient. We would like to, but... and defending. You know that doctor ordered that medicine for you for a reason. You're defending the physician. If patient doesn't want to take their meds, patient doesn't want to take their meds. Okay, you will find you can't force them to sleep. That's going to be in the daily report, and that has effects on their behavior. And again, like I always tell students, if their behaviors start escalating, it's not what you said. Unless you're just out in a zone, like a different world, where you just don't have a clue of what's going on, it's not you. You did not set them off. It's something else that has set them off. Okay? Okay, so what do you want to do? These are the do's, okay? Silence. Let them think and reflect. Don't keep probing. Silence can be very uncomfortable. It's uncomfortable for me. But I have found in this environment, I use silence a lot more. Just because I don't want to put my foot in my mouth, So, and it can allow the client time to talk, okay? You want to use your therapeutic communication skills. And appropriate, you're very conscious of your nonverbal, so that client will open up to you. Okay? Again, describe, that's what I was trying to do with a man who tried to commit suicide. Okay? And this is always a big one. I use this a lot. You can't go wrong with restatement and paraphrasing. That's just you're attentive to what the client is saying, and you're really trying hard to understand what they're saying. You're not judging, you're not approving, you're not disapproving, you're not giving advice. You're really trying to understand and listen. So again, as you move now to these psychiatric areas, your ears are on. You're really trying to look at their statements. Okay? And keep broad openings, open-ended questions. Can't go wrong with that either. Okay? You can't go wrong. But again, if a client's behavior escalates, it's not you. It is not you. Okay? You will see, and guys, to tell you, when we go to the VA, like, you can't even lift the chairs. Jason could lift the chair, but you can't. Somebody like us, we can hardly move the dang chair. It's so heavy. What you'll find too, there's nothing on the walls. Nothing that can be pulled off. If it's on the wall, it is like cemented in the wall, okay? A lot of safety features, okay? You have to remember, you're dealing with patients who tried to commit suicide. No strings, even pens. You will find they often just give them the inside of the pen. You can't give them the whole pen. It's just the inside. So really have those observational skills in place. You will be blown away, okay? Their rooms are not much, okay? It's a bed that's mounted to the ground and a mattress. That's it. That's it. Okay? So it's, you'll learn a lot, as Ms. Hyde said. You will learn a lot. You will think about this. You will think about your own coping skills. And it helps you to grow and be a better nurse by looking at this side of care. Okay. Most of you, I hope, will be like myself. You find it fascinating, but there ain't no way on earth I would do this every day. I am sorry. I could not do it. There would be some of you that are like, I can't wait to get out of here. I can't wait to get out of here. Generally, in my years of teaching, 1 or 2 students in a class that this will be their passion to have this as a career. Okay? Again, I've already gone through a lot of this. Again, paralanguage, what is that? Be very cognizant of your volume, of your voice, things of that nature, your pitch, very just a normal inside voice. So now, because I can see you guys are just extremely, is this helping you in any way as far as being prepared for tomorrow? At least you can go and have some idea of what's expected of me as I go to this area that maybe I have never been here. Do any of you work in psych? And that's usually the case. Oh, you have, Shannon?
I do sit-in work with Maxim, the healthcare agency, with psych patients, but that's very not so often. But I have come across some kind of psych patients.
And again, another reason to why I think you need this additional info to help you to know what, again, is expected of you, what you're going to see, is because the majority of my students don't. This is not what they encounter. I was going to say, in the acute care, go to IMC. You can learn everything you want to know about psych. But yes, the acute care settings, we're getting more and more psych patients, which is very unfortunate, as I was talking with one student about the lack of resources in the United States. It's sad. You will find that probably to be the hardest encounter is when you see a patient that you have talked to and you know they have nowhere to go. Their families have disowned them. Why? Many of them not only have a mental health disorder, they have a substance abuse problem as part of a coping mechanism for what they're trying to deal with. That is called a dual diagnosis. And there are others that have a criminal record and they go to court there. Okay? So, again, it's just very disheartening when you see someone that is now going to be dismissed from the facility and they have nowhere to go. And they put their clothes, guys, all they can put on is their shirt, their pants, and their shoes. Okay? They have to go outside the locked door to put on a belt and ties to their shoes. Those are things you don't think about, isn't it? But yeah, when you watch them, they have no laces.
Yeah, if it's a female, they probably don't have the bra either.
Right. No belts. You can't have that. It's a suicide precaution. Okay? So it's very disheartening. And it's very, your heart will bleed for some of them. I mean, you just walk out of there going, you know, I'm crazy. Thank you for my life. Because it's very unfortunate. And these are people that fight for your country. And that's what is so hard. So hard. And I say, guys, I mean, we see females too. And just before we break, she was bipolar. And you're going to see a lot of bipolar patients. And in war, that mania made her a great killer, right? It made her a great fighter because in that manic, euphoric episodes, she was evil. So she comes back, she spends every dime she has. Every dime she has is now gone. She tried to commit suicide and there she is in the VA trying to get help. Because now that raging fighter is that accepted in our societal norms. So those are things I want you to think about as you enter these facilities. So you feel more prepared. You feel more ready to learn as much as you can about these patients. Okay? So guys, take a 15-minute break. You know, review the questions to just keep at it. And I'm hoping that you will find it to be better and better as you answer these questions. Again, don't look at the answer. All right? I want you to really try to answer this based on what you can apply as far as your therapeutic and non-therapeutic techniques. Okay, so you guys, I know you can read, but this you've got a mother's notified that her child was killed in a tragic car accident. She says, I can't bear to go on with my life. Now, this is critical, empathy. So the student has to have in their mind, what would be a response that is empathetic? Okay? So let's look at our choices. The situation is very sad, but time is a great healer.
You're telling her it's okay. No.
What?
You're telling her it's going to be okay.
Exactly. So, again, you're basically giving her false reassurance, right? You are sad, but you must be strong for your other children. Okay, that's giving advice. Excellent. Once you cry it all out, things will seem so much better. Exactly. It must be horrible to lose a child, and I'll stay with you until your husband arrives. Okay, you can see that is showing empathy. Okay, why is that empathetic?
Because the just showing an understanding,
And you're comfortable.
and then you're gonna stay with her and make sure.
Exactly. It's you showing you are listening to this client of what she is saying to you, and that you heard her with your active listening, and you respond in a very empathetic manner, saying that it's horrible to lose a child. Again, it's not focusing on the nurse. It's saying, I'll stay with you. Okay, so it's not about the nurse. It is about the patient. So excellent job. Again, if you read in the literature, it is considered to be one of the most important characteristics. Why? Because it requires active listening to really understand what is going on. Okay? So, let's look at our next one. Okay, which therapeutic communication technique is being used in the following interaction? My father spanked me often. The patient is saying to you, the nurse. Your father was a harsh disciplinarian. So, is that technique restatement?
Yes.
Offering general leads? No, that's not. That is definitely not offering a general lead. Is it focusing?
No.
No, you're not directing it toward a particular topic. Accepting?
No.
No, you're simply restating what the patient has said to you, the nurse. Now, what might you do next to get more information?
How did you feel about it?
Would you like to share?
Okay, say that.
Would you like to share?
Okay, but be careful with would you like to share your feelings about that, because they may say no.
How do you
How do you
Say it again. Tell me about your feelings.
How did
You really have to be thinking about, well, they can just say yes or no. And the subject's going to end. So, again, tell me more. Okay? So, you really have to think about those things to get them to open up. So, you're constantly thinking about open-ended questions. Okay? I hate this thing. Y'all know. Y'all are right. Okay, so you guys are correct. You're repeating the main idea, and this is what I've tried to do. Not only give you an answer, but again, enhancing your knowledge with that rationale. Okay? And that's what I want you to be doing on your exams. Okay? So, again, you're repeating the main idea of what the client says. And again, it shows the client that you understood, and you're going to then proceed with an open-ended, broad opening statement to then have more information. Okay? Is everybody with me? Okay. So this is another one. And again, guys, I tried to give you some that would be helpful for a review. Okay? I think I've put a couple on here that are going to be more of what you're going to see on like an exam. Okay? But then, again, I just want to include things for the review. Which therapeutic communication technique is being used in this interaction? The patient is saying, when I am anxious, the only thing that calms me down is alcohol. Remember, don't raise your eyebrows. Okay? Don't shake your head. I understand. I understand. I'm in nursing school, you know. No, don't. You're very conscious of that nonverbal, okay, behavior. Other than drinking, so the nurse says, other than drinking, what alternatives have you explored to decrease anxiety? So is that reflecting? No, you're not reflecting on the main idea. Are you making observations? No, that probably would have been a maybe for a lot of students. Formulating a plan of action.
Yes.
Giving recognition. No. Okay? So the nurse replied with, other than drinking, what alternatives? So again, you're trying to give a broad opening. You guys see that? Okay? By helping to formulate a plan of action. So essentially, what are you doing? You're trying to get the client or the patient to explore alternatives. It is very easy for us to stand there and say, what? You need. You need. Right? How many times do we do that on the medical, surgical area? You need to turn cough deeper. You need to get up. Do you not realize you're going to have a clot in that leg? This is a different animal. It's about their feelings, their problems. Okay? So it's very easy. If you say you need, it's okay. It's okay. Again, this can help the client explore, again, trying to keep anxiety down. Okay, so your next question, you're interviewing a newly admitted psych patient. Which of the following statements is an example of offering a general lead? These are the types of responses that we want to use. Okay? Do you know why you are here? What did I say?
Why?
Why's in it? It's a no. Are you feeling depressed or anxious? Yes. No. Yes, I see. Go on. This, you can't go wrong with this one. Okay? Can't go wrong. Please go on with what you're talking about. Okay? Can you order the specific events that led to your admission? No. It's accusing. But you know what I'm going to say? No. And you're going to get up and say, well, that ended nicely. Ended real nicely. Okay? I get work out of this person. And those are things, again, like when if we're going back to the break room or wherever where, it's locked and people can't get to us, I often ask the student, what types of techniques did you use? Did you find them beneficial? Were you able to, really look at therapeutic technique and what they said and not in their nonverbal communication? Did you get the information that you really need to try and get from this? And if not, that's okay. We're going to review and go back and do it again. Figure out something. Okay, again, these are the general leads. These are the ones as I hope you'll review some of this tonight. So again, it's kind of in your mind and you don't walk into the areas, psych areas going, I honestly don't know what to say. Okay, let's not do that, okay? We want to have some idea, okay? So you've got at least some that you can use that you can always see as therapeutic, okay? Now the nurse is talking to the patient. Things will look better tomorrow after a good night's sleep. I say that to a student. Talk about false reassurance. It's ridiculous. But we do it. Because we're trying to be, sympathetic. We're trying to get you to look at coping, but no, it's false reassurance. Okay, so is it giving advice? Defending? No, you don't want to defend. And again, I've tried to put these up there, trying to reiterate non-therapeutic. Presenting reality? And as you already know, because I say it to the students, and that's not good, that it truly is not therapeutic, okay? You are giving them false reassurance. And what does that mean? See, that's why I wanted to take this a little bit further in the theory. What does that mean? You're basically telling them there is no reason for them to be worried. There's no reason for you to be worried. And you're sitting there looking at me, I'm just barely passing. Yes, there is some reason for me to be worried. So, this is not one that is good to use. Okay? Okay, a client diagnosed with post-traumatic stress disorder related to a rape is admitted to an inpatient psych unit for evaluation and medication stabilization. Which therapeutic technique might a nurse use as an example of a broad opening?
No.
Why?
It's saying when did you go,
That would
Might be blaming it on
That
them.
would make
Like,
her
what were you doing?
report it on
Accusing.
Yeah, like
Accusing.
her situation.
You're trying to put blame on her, too.
Yeah.
Mm-hmm. That's exactly
So
right.
you're asking what happened prior, so you can say, what was you doing to practically asking her what was she doing to get raped? Or she can take it like that.
Okay. Right, it's blaming. What would you like to talk about?
maybe.
Definitely possible.
What if she said nothing?
Nothing.
Yeah, like I say, nothing.
I notice you seem uncomfortable discussing this.
Well, yeah.
Yeah, I don't know.
Maybe.
Yes or no?
I had some four.
Yeah.
Four.
That's nice too.
How can we help?
How can we help you feel safe during your stay here?
Yeah.
Oh, it is broad.
Yeah, so
It is too. It's got to be two.
Only problem.
I would go with 3.
Three.
Two.
3.
Dreaded therapeutic communication class. Dreaded. I hate them questions. I hate them.
Two, give her the opportunity to talk about what she wants.
Anything in there
Yeah.
that's
To
left
get her comfortable with it,
Exactly.
trusting.
It allows her to open up and express her feelings and then direct your conversation from there.
And really, look at this. I notice you seem uncomfortable. Is there anything in that in this?
No.
And you know why I point that out? Do you know how many times students start putting stuff in here because it's in their mind? They see this rape victim
Uncomfortable.
all uncomfortable, and so they put it in here, and I'm like, where is that? I don't see it. But you become so certain that it's there, okay? So, again, you have constantly, what is my whole point of this? You have constantly got to keep what is therapeutic, what is not therapeutic. What is therapeutic, what is not therapeutic. So, which one?
Two.
You are right.
What if she said nothing? Isn't that a closed-ended or closed-ended? Not question.
Not, okay, if she said nothing, what would be your response?
Tell me how you feel.
Tell me why you wouldn't want to talk about this.
Now there's why.
Oh, why?
Why?
No, put why. Tell me
Tell me more about your situation.
Tell me more about your situation.
But then you're probing.
Well,
Okay? So let's do this realistically. Do you think silence might be appropriate?
no.
Yes.
If she said nothing?
Yes.
just,
Elementary.
just stare at her and
Well, let's just play that.
Silence. What else? Now, granted, this patient has just been raped, and what did I say? Be very careful of touching these people. How about, my name is Suzanne. I'm your nurse. I care about you, so I'll sit with you. Without raising my eyebrows. And in my mind going,
And then when you're ready to talk, I'm ready to listen.
there you go.
Very, very
Hey guys, this thing doesn't all, this is not just for psychiatric mental health. I'll give you an example. The funniest story that I ever had, though it was really uncomfortable for my student. We were on a med-surg unit, and this was a second semester student that I was in the room observing, doing physical assessment. And he's talking to his patient, and the patient looks up at him and said, "Am I going to die?" And he said, "Let me go check the rats." And oh my God, I can't laugh. The student goes barreling out the door, and I'm left to say, "Well, did your doctor talk to you about coming in with a therapy communication?" But it was sort of like,
The student didn't hear one word that patient said. Not one word.
depending on what the lab showed, and I finally talked to him later, and I said, "Now, what were you going to tell us?"
Your lab surgery
He wasn't playing it. You're right. He was not playing it. But this works with med-surg patients just as well as it does with clinical patients. So think about those therapeutic techniques that she's talking to you about in every rotation that you go through.
Yeah, you really have to stop and really kind of get it ingrained. Oh, the dreaded. You dread it.
You mean to tell me I've got therapeutic communication select all their blah? Are you kidding me, Miss Rella? I can't answer that.
That's what I heard. I said, yeah. Okay, so which should be included?
No.
No.
Why?
The nurse.
Because it includes the nurse.
There's a nurse. Okay.
No.
What does that mean?
Well, yeah.
Therapeutic termination. It means you don't do what that student did.
And not go back.
You ran out of the room and you had no intention of going back. Because you know what? You made me nervous. So,
Yes.
yes. They're people, guys. They have a right to know that our conversation's ended.
Yes.
Definitely.
Yeah.
Yes, that's with, these are with any patient.
Yes.
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 So 2, 3, 4, 5.
3, 4, and 5. You know, students, now I will tell you, would come to me and said, it was like they wanted to put a formula here. You know, well, it can only be 2 answers. Where have you taken NCLEX? You know, or it can only be 3. It can never be all of them. Well, I found 2 in the NCLEX books because my heads are in them now a lot. Looking for these there, and all answers were right.
Not only support
No,
the
yeah.
state board, and it says no.
That's to determine why. What did I tell you NCLEX is about? Safety. Are you safe? That's why. Yay! 2, 3, 4, and 5. Okay? Okay, insight, collaboration, meeting the needs, ensuring therapeutic termination. Again, this had nurses needs. It's not about you. That's with any patient. It's not about you. I don't know what the pills are for or why I'm taking them, so I don't want them. That's not just with psych patients. That's with pretty much anybody. Okay? Giving information. Yes, it is okay in some situations to give, information.
No.
You what?
Must.
Why is that non-therapeutic?
You're telling them command.
That's a threat. Have you heard people in the hospital? I don't know, maybe you work with nurses who never say, if you don't get out of bed, I am going to call a doctor and I'm just not going to come back in the... Have you ever heard that? That's threatening. The doctor would not prescribe these pills if they were harmful to you. That's defending. Excellent. Do you feel this way about all your medications?
Accusing.
Yes.
Non-therapeutic.
Yes. This medication will help to improve your mood. And that's why, again, what are you taught in 111? When you give a medication, it is your responsibility to tell that patient what that medication is and why they're getting it, right? Okay? Because they are to know that information. And I may finish up a little bit early. Are you okay with that? Okay. Because I don't want to start farm. Okay. Okay, 2 more questions. Again, these I've tried to again put the rationales. These are to, hopefully you will review prior to exams. Like I said, where you are definitely, going to see these throughout with the disorders. And the first topic is bipolar and major depressive disorder. Violence and schizophrenia.
Eventually.
Yeah, and personality disorders. So this is where you're going to see these questions. Okay. So we're in a different setting, outpatient clinic. I am so tired of these medications. Which nursing, this is more of like what you'd see on an exam. Okay, not what technique is it. Which nursing response is best to encourage the patient to elaborate further?
No.
Why?
You just restated. I see you've been taking your... Now you're accusing.
I'm tired of this.
We are taking them.
Yeah, accusing.
Right. Tired of taking your medications?
Restating.
Okay, restating. Let's discuss different ways to deal with your problems. Right, you just implied they have a problem. That's, again, that is putting judgment on these people. How would your family feel about this if you stop, I guess it should be stop taking your medication. Sorry, typo. How would your family feel? Do you care about the family?
But you're not really.
Well, you're teaching them to care about family.
You're like punishing them and telling them you're gonna use that against them to make them do something they don't want to.
Okay.
Elaborate further and do 2.
Okay, so which one? Two. Answer 2, you're restating. Again, it always goes back. And guys, I have had my head in books with this, and it always goes back. Do I know the difference in therapeutic and non-therapeutic? It's theory. NCLEX is theory driven. So restating lets the client know, okay, that you have understood what they are saying. Number 1 is giving recognition. 3, it was actually formulating a plan. Again, this can have the client look at a bigger picture, but that's not really addressing the issue of what the client said. Again, remember what I said. Oftentimes students will pick something because in their minds they start seeing, they see family, and then they start putting that in the question. Don't do that, because you will really get messed up with these subjective types of questions, okay? You've got to look at only what the question's asking you. What is therapeutic? What is non-therapeutic? If you do that, you're going to get the majority of it, okay? But I felt like now you've got a little bit more information under your belt, more time to practice, more time to really think about this, because, you know, this is not something you get like, right? I didn't. You know, I've had my head in books for hours. So, okay. And our last question of the day. So, this patient is telling you, the nurse, I am all alone in the world now, and I have no reason to live. These are the types of questions you will definitely see on an exam. Which response by you, the nurse, is best to encourage further communication? Okay, so the patient says, I am all alone in the world now and I have no reason to live. And the answer is not, let's go check your labs. Or, you know, let me go check your chart.
I'll just bet sheet while I go check the
Yeah. Okay, you sound like you are feeling lonely and frightened.
Yes.
Possible?
No.
Why do you think that suicide is the answer to your...
No.
You see why? No. I live by myself and know it can be lonely and frightening. Okay, yep. Hang in there. Things will work out. Loss reassurance. Y'all done good. I'm proud of you. Very proud of you. Okay, again. And these provide your rationales. Use this as a review prior to your mental health exams. Like I said, in particular, when we start bipolar.
We were talking, and like, I probably would have ended up picking that one because the other ones don't make sense. However,